work in the labor officer here for almost 20-30 years in Guntur. So I used to visit frequently during my medical school. So I'm very happy. This is the second time I'm coming to this institution. Last time on the time of screening, early detection campaign, that went very well. Thank you for the opportunity to be here today, Srinivasan and all the staff, superintendent, the principal, what I am going to show you is where are we in cancer treatment? What are some of the new things? I hope there are some postgraduates here. So this is going to be an inspiring time for you. If you want to become an oncologist, a molecular scientist, as someone, a pioneering physician. You know, I was sitting like you in the audience in Guntur Medical College when I was a student and a postgraduate. So I was inspired by similar lectures. So hope this will help you to get inspired and do something for this specialty, medicine and oncology. This is the lecture I gave a couple of months ago in Telangana Academy of Sciences. One of the Shirodkar Memorial Lectures I gave in Hyderabad. Next slide. Your point went down on the American Association of Cancer Research organization in America. They publish these reports annually. This report is simple to read. What I want you to read is the first arrow going up. Global cancer cases in 2010, on the green shadow, 13 million new cases. And by the time we reach 2030, which is only a few years from now, 7 years from now, that number goes to 21.5 million cases around the world, which is almost like a doubling number, alarming number, from 13 million to almost 22 million. On the other side, you see at the green arrow again, global cancer cases estimates 15 million in 2015 and by 2035 is 24 million. These are alarming numbers. I don't want you to get upset about that. But what is happening is these increase in cases, numbers in millions, is not going to happen in Western countries. It is going to happen in developing countries like India. So unless we wake up, do something in terms of early detection screening, these numbers are going to go up, especially in countries like India. But there are ways how to put this incidence switch on dimmer switch, early detection, screening. This we can reduce the incidence, annual incidence, and probably annual death rate also. Next slide, please. So what I'm going to share with you, what have we done in the last 25, 30 years in oncology, and where are we going from here? What is that word of hope I'm going to tell you? There is we can be very hopeful that we will be able to control cancer. It's not science fiction anymore. Evolving paradigms. Continue. New discoveries in cancer, next one, and advances in clinical oncology. Evolving paradigms, keep going. When you are in medical school about 20 years ago, or when you read your textbooks, your pathology department, your pathology report shows only 3 things. Size of the tumor, what type of tumor, and what grade of the tumor. Basic things. Based on that, we used to prognosticate whether the patient is going to survive 3 years, 2 years, 5 years, or 10 years. But that has changed to secondary predictors, tumor markers, ploidy, and receptors. That's not enough. We made even more advances. Now we are in tertiary predictor level, P53 gene expressions, EGFR receptor expressions, molecular and proteomic profiling. So our understanding of the underpinnings of cancer, molecular underpinnings of cancer, are better known today than 20 years ago. So that is the take-home point for us. This slide appears complicated, but not. I'll explain to you why I'm saying that. In the center, we have a pointer I have shown you, in the bottom of this slide, you see the DNA, written as DNA. That is the center of the tumor, and on the periphery is the cell membrane. The central DNA, we don't know what signals it gets to get multiplied. Get your own blood supply, get metastasized to other organs. Who is giving this signal to this DNA? A normal replication becomes abnormal replication. Where is the signal coming from? We didn't understand for a long time, for a very, very long time. We thought by just knocking down the multiplication by chemotherapy, radiation, surgery, we'll be able to eliminate that. Without understanding where the signals are coming from the center area to multiply. Take for example, I give this example of a wheel. Wheel has a peripheral rim, spokes, and a central hub. The central hub is the nucleus. So where is that signal coming from to the central hub to multiply? Is coming from the peripheral membrane through these spokes here. So the peripheral membrane has a lot of receptors, which we understood only in the last 2 decades ago. This peripheral membrane sending signals through the spokes, multiply, develop your own blood supply, go metastasize, go to liver, go to brain. All that, the signals are coming from the peripheral rim. That's what you see. The second point here is you see here that on the top, extracellular domain, cell membrane, and intracellular. 3 areas, you know. Remember this for again for students. Extracellular domain, cell membrane, intracellular domain. So the signals are coming to the center from these 3 various sources. From outside the membrane, on the membrane, inside the membrane. So these we come to know, each signal has a specific nasty function telling the DNA to multiply. So what we did in the next generation, last 15 years ago, we found drugs to block these signals coming from the peripheral rim. If we block one signal with a medicine, that potential to become metastatic will be gone. The second signal with Avastin-like drug, if we give to patients, the nasty function of the cancer cell to develop its own blood supply is gone. So each signal, we are disarming the cancer cell. So these are called targeted drugs, designer drugs, each drug. So if I block one drug, the cancer survival improves. For example, Herceptin is caused by one signal in breast cancer. If we block the signal, the survival improved by almost 40%. Tarceva, EGFR signal. If we block that signal with a single oral pill, you can give them 5-10 years of disease-free interval in metastatic lung cancer. Look how powerful blocking the signal is. But say for example, chronic myeloid leukemia, CML, if we block the tyrosine kinase inhibitor signal with one pill, Gleevec, oral pill, taken daily, you are curing chronic myeloid leukemia. Look how powerful understanding is about cancer biology, molecular underpinnings of cancer. So like this is very profound, very important diagram. Next diagram, next slide please. Next slide. Look at all the drugs we developed to block each signal. One signal here, you see here, Herceptin blocks that signal and improves survival in breast cancer by 30 to 40%. The Gleevec in chronic myeloid leukemia, rituximab in lymphoma is blocking another signal. Improves survival in Hodgkin's disease, non-Hodgkin's disease, almost by 30 to 40%. Improved cure rate. This is not control, cure rate. And like the same thing, rituximab, all kinds of drugs we develop, what I just told you are called designer drugs, are targeted drugs. We are targeting one signal to block it. So these are called designer drugs, targeted drugs, whatever name you give, it blocks it and improves the cure rate, not just control rate. So that's a major link in understanding cancer biology and blocking it, improving the cure rate. But the caveat here is each drug blocks only one signal. But tumors are very complex. It's not one signal, one pill won't be able to help. Some cancers have multiple populations. So if it has to be, if we want to address all signals with one treatment, what is the treatment? Immunotherapy. Immunotherapy, which is the new game changer in cancer treatment, is blocking all those signals, targeting all the signals and giving. Immunotherapy is not like a cancericide, like it won't kill the cancer cell, it will improve your immunity, that the cancer cell is eliminated because you have improved the T cell function. So targeted therapies, I just narrated everything here, what we have done about many years ago. Herceptin in breast cancer improves cure rate. Avastin for advanced lung, ovary, colon cancers improved cancer cure rates in those areas. Rituximab in B-cell lymphomas. Arbutex in head and neck cancer. Tarceva, which is the EGFR drug in lung cancer. So these are major advances. The next one I'll share with you, immunomodulation is the new frontier in cancer treatment. I just told you what is the immunomodulation function here. What is happening is when the cancer cell is developing in your body, in any patient's body, it does two things. It produces two nasty antigens, two nasty substances. One is called CTLA4, the other one is called PD-L1, two nasty substances. What those nasty substances do in the body, it knocks down your command and control center in your body of the immunological control. If you have an infection, your immunity fights it and you eliminate the infection. If the command and control center is destroyed, your body cannot fight. So these two nasty antigens developed by the cancer itself is knocking down your immunological function. So what happens? If you develop drugs to prevent that, to break through that molecular shield the cancer is producing in your body, molecular shield called immunomodulators. Immunomodulator drugs, like almost like a arrow, Rama Banonder, it pierces through the molecular shield and improves your own immunity to fight the cancer. So those are the drugs we developed, and the entire America and Europe were developing. We are spending almost $500–600 billion on the research. So it's not science fiction. They are being useful. They are available in India also, these drugs. Next one. Next one, go to the next one. Yeah. I told you about the CTLA antigen, which is a nasty substance. I don't expect you to read all that. It will kill our immunological function in the body. Next one is PD-L1, PD-1 and PD-L1 antigens. So these two, remember, are the substances that are produced by cancer cell to destroy your body's immunological status. Next one. Next one. Next. This, I'm sure most of you are medical, I think, and some of them are also non-medical. I'll show you what is happening here. I told you, immunotherapy works on all targets in the body. So if there is a metastatic disease in the body, it should eliminate everything, any various cell types. So here, this is a lung cancer patient. If you see closely, he has two liver nodules here, and there is a floral-based nodule here. I hope everyone can see that. There is a presacral mass. Presacral mass, the metastatic lung cancer. And what we did, we used the synergy between radiation and immunotherapy. We just radiated the liver with few SBRT treatments and put him on an immunomodulator drug. Immunomodulator drug. See on the next panel here, these liver nodules disappear, which is the area we treated, and the floral-based mass disappeared, and the presacral mass disappeared. This type of miraculous treatment we never saw before immunotherapy. And this patient is arrived 12 years later deceased with metastatic lung cancer. So these new generation of immunomodulators are helping patients to survive longer. In fact, if you look at American Cancer Treaty numbers, 5-year survival for non-small lung cancer used to be 5% at 5 years. Now that number has reached to 25% at 5 years. Cure rate, metastatic. These numbers we never heard before. So there is a lot of hope if we identify what type of marker we need in this patient, what type of treatment we need. Next one. This gentleman, you all know him, our past president of the United States. He has developed melanoma, metastatic to brain, bone, lung, liver, everywhere. And we treated him with immunotherapy. And he is now followed 13 years following them, completely negative scans everywhere. So this is the type of dramatic response you can see. You may not see in every case, but if the biomarkers are positive, this kind of result you can see. Next one. Oh, these two people, go back here. One, I told you about two nasty substances that the cancer produces to destroy your immunity. One is CTLA, one is PDLA. This gentleman got a Nobel Prize for discovering CTLA. That gentleman from New York got Nobel Prize for discovering PDLA. That is the kind of scientific breakthroughs happening, and I'm sure you are aware, you should be aware what is happening. Next slide. Then Cancer Genomic Atlas has gave us a different dimension to our understanding of cancer. Why cancers are happening? What is the molecular underpinning of cancer? This happened during Bill Clinton's time. We spent billions of dollars to develop human atlas for cancer, and genomically we profiled 20,000 cancers. So we have atlas for why each cancer is happening, what aberration in gene that is causative for cancer. Next one. Next one. Okay. This is important. This analysis, Genome Project, has given us a lot of information, significant information. Number one sentence is important here. We identified 3.2 billion what we call base pairs in these cells. Roughly 99% are identical between two individuals. That means a person sitting next to you here, between the next one and you, 99% of genes are identical. That 1.1% is making you unique who you are. That 1.1% is the reason for when you develop cancer, because that 1%, 0.1% is enough to make it totally different. So that we need to analyze that 0.1%, see the molecular profile of that, then we know why you got the cancer. What is the gene mutation that causes your cancer? Very important. Next slide. Yeah, this is important, just like other slides. Take for example, this is a lung cancer on the top, lung cancer patients. Take 100 patients, lung cancer stage 1, 2, 3 or whatever number, all same stage, same males or females, same size of the tumor, no same, everything identical. You give same standard chemotherapy. It works in 50%, 60% of the patients. In 40% it won't work. Why is that? You selected the same type of tumor, everybody same age group, but only 60% are benefited, 40% are not benefited. That means we are shooting in the air with chemotherapy, not knowing what is the profile of each individual cancer cell in individual body, individual patient. Next one. Then when you start doing that molecular profiling of cancer cell, when you do a biopsy, pathologist doctor here, you can identify what is that underlying molecular pinning for each type of cancer in each individual. That is different. Even though the stage is the same, the pathology is the same, age is the same, everything. Look at how many, the same group of individuals, when we did the molecular profiling, how different it is. Next slide. Next slide. Look at this. If I use the same drug, same mantra for everything, it doesn't work. It's on the top panel, drug is toxic and beneficial. Okay, no problem because patient got benefited. On the other side, the red one, drug is toxic but not beneficial. Totally, we wasted his time and our time and then patient's money also. It's not useful. And in the bottom line here, orange is drug not toxic, not beneficial. When you treat 100 patients, only that small group is benefited by it. Look at how much money you can save, misery save to the patient and family. If you know if he is going to be really benefit, otherwise change the therapy to something else. So this molecular profiling is a great breakthrough, and here it is also available in India also, next generation sequencing, NGS. We can identify what patients are really benefited by your treatment. Then if you are not benefited, use a different type of treatment. But don't waste your time and patient's time. Then I'll go to clinical oncology advances, which is easy for all of you to understand. What advances? Machines, technology, radiation oncologists love machines.